Ezekiel Emanuel, Special Advisor to President Barack Obama on Healthcare. Thanks for joining us.
Thank you for having me. It's very nice to be able to broadcast from Vienna.
So here in Vienna, there's been a lot of characterization of funding for HIV AIDS, flatline, decreased. How do you characterize funding for HIV AIDS, specifically PEPFAR?
Well, the fact of the matter is that we have increased the funding. The President has increased the funding for all of global health, and he's increased the funding for PEPFAR and HIV tremendously. It would have been easy in the face of the economic downturn, the loss of 8 million jobs in the United States, for this to be a moment of retreat, this to be a moment where the President says we can't afford helping the rest of the world, especially on HIV. And wasn't the response. Every year he's proposed a budget, 2009, 2010, 2011, he's proposed an increase in PEPFAR funding. There has not been a retreat, and it actually distorts the conversation and discredits actually many of the advocates who are saying that we're rolling back, we're not funding PEPFAR. We are increasing every year. This past year, the budget for 2011, the President increased the total global health budget by 8%. So he is not pulling back from global health or HIV AIDS.
So how do you deal with that mischaracterization here? What is going to be your work here at the conference over the next week?
Well, it's really to present the facts. As I like to say, we can have a disagreement about policy. There are honest disagreements about policy. We can have disagreements about priorities, but we cannot have disagreement about facts. And the facts are just out there in the budget. And anyone who says that we are retreating, we are cutting back, simply is mischaracterizing what the President has done. And it, again, discredits the people who are speaking because they are distorting the President's record.
Looking forward to the Global Health Initiative, which is obviously going to incorporate HIV AIDS and a variety of other global health issues. One thing that the U.S. government is going to be working on is this idea of country ownership. I thought what you said yesterday in a session about what country ownership is not was actually very helpful in understanding what it actually is. So what is country ownership not?
Well, one of the things it's not is an opportunity to sort of cut and run, to say, okay, you own the problem and we're withdrawing and we're going to decrease our funding and get out of this area. That has not been the philosophy. One of the things I also said is that country ownership is one of the principles in the guiding the Global Health Initiative, but it's married to other principles: sustainability, integration, getting results. So it's very much not about trying to terminate and restrict our interaction with the developing world and our commitment to them to improve the health of the world.
One other point that you made yesterday that I thought was interesting as well is what the private sector does well in terms of if they know something is failing, they'll cut it off, but that's not something that government typically does. So how do you think that can change, and can it change?
Well, one of the challenges I do think for the HIV AIDS community is to use all of its passion, its creativity, its just excitement about the issue and about helping people, to focus on what we can do better. And in fact, I think learning from our failures is absolutely essential. The private sector does cuts bad programs much more quickly than governments do. Governments have interest groups, they have other considerations, but I do think that if we care about saving the most lives possible, one of the things we really have to do is to make efficient use of our money. Every time we waste a penny, we are not saving a life. We are not helping someone with HIV. And one of the things I think the advocates really need to focus on is what isn't working and redirect those resources to things that are working, because it's vital that we do as much as we can with the resources we have. There are people dying, as the advocates say, and one of our responsibilities, both in terms of the government but also in terms of the advocates, is to target what we have in the most efficient manner to make sure we can get to as many people as possible with our resources. It's not just an economic obligation, it's a moral obligation, and the advocates need to put their passion, need to put their energy, need to put their creativity in that.
Can you give us an example of a program that you think might not be working?
Well, one of the things we know is that there's huge variation in the cost, for example, in testing and identifying someone with HIV. There's variation in the cost that within a country of treating someone. There's variation between countries and how much it costs to treat a single person on HIV. And we need to identify where's that variation coming from and how can we narrow it. Some of it's about volume. Once you put a program in an urban area, you have many more people. We understand that. But there are other inefficiencies that we need to be able to get rid of. I'll give you one example that I think we're going to be looking hard at. That's monitoring after you get someone on treatment. Right now, people come back every 3 months. Well, where do we get 3 months? Why isn't it 6 months? And is 6 months just as safe and just as efficacious as monitoring every 3 months? If it is, you can save about half the money and half the human resources on monitoring every 6 months as opposed to every 3 months. So those are the kinds of questions we really need to drill down on, and we need to get the data and then make the appropriate policy changes.
Last question for you. There's also a lot in the GHI about coordination of care, integration of services. So can you tell us about how you see that playing out in maternal health and HIV/AIDS?
Well, we actually heard from the Deputy President of South Africa last night in his address at the town hall sponsored by UNAIDS, the fact that they in South Africa are integrating their testing. They're not just testing for HIV and screening 15 million people for HIV, they're actually taking it much more broadly. They're integrating it with prenatal care, with postnatal care, with screening for hypertension, with screening for hypercholesterolemia, for diabetes, for TB. So they've gotten the message, and we think that's a message that everyone should get. We get much more health impact. Identifying a person, bringing them into clinic is about the most expensive thing you can do. Just testing on one disease when they might present with many other diseases is very important. But in addition, we understand that we've got a proven technology that can get rid of mother-to-child transmission. We have to integrate that with prenatal care, and then we have to integrate treating kids who have unfortunately gotten HIV with their vaccinations to make sure that they get the right antiretroviral treatments to prevent further spread. So there are lots of things we can do. And again, part of the issue for the AIDS community, part of the issue for the implementers is to think creatively about how we can be more efficient. We know that these treatments work. We know that we can have a positive impact on a community, and we need to get the most we can out of every dollar we spend.
Dr. Emanuel, thank you so much for your time.
Thank you for having me. Appreciate it.